Welcome. Today, we are going to demystify the updated CAP protocol for cancers of the pharynx. If you're a pathology trainee, you know just how tricky these specimens can be. So think of this as your practical guide, a clear, step-by-step approach to nail these cases every single time.
So, let's set the scene. A big, complex pharyngectomy specimen lands on your bench. You've got the primary tumor, a whole neck dissection, and this long, intimidating CAP checklist staring back at you. It can feel like a lot. The big question is, where do you even begin? That's the roadmap we're going to build together today.
We're going to follow this specimen's journey from the moment it arrives. First, we'll figure out if this protocol even applies. Then, we'll dive into the tumor itself, check out invasion and margins, hunt for positive lymph nodes, and finally, put all the puzzle pieces together for that final PTNM stage.
Okay, first things first, the protocol scope. Seriously, before you do anything else, you have to answer this one simple question. Does this checklist even apply to the specimen in front of you? Getting this right from the get-go is absolutely critical.
So to start, let's get our bearings with a quick anatomy refresh. This protocol covers cancers from the three main zones of the pharynx. You've got the nasopharynx way up top, the oropharynx right in the middle, that's where you'll find the tonsils and the base of the tongue, and the hypopharynx down at the bottom.
So, when do you actually use this thing? Here's the most important takeaway. This protocol is for resection specimens only. We're talking about the big surgical pieces, not those tiny little biopsies. It's for carcinomas, like your standard squamous cell carcinoma, or SCC, plus neuroendocrine and salivary gland types, and even mucosal melanoma. What's it not for? Sarcomas and lymphomas. They have their own rules. And you also don't use it if the patient had therapy and there's no cancer left to find.
All right, we've confirmed our specimen fits the bill. Now we can get to the good stuff. Section 2, characterizing the primary tumor. This is where we start digging into the details of the cancer itself.
For any tumor, you've got to document these four key things: its exact location in the pharynx, how big it is in centimeters, the histologic type, and its grade. These are kind of the basic building blocks for your report, but for oropharyngeal cancers, you're about to hit a major fork in the road. And I'm not exaggerating here. There is one single question that will completely change how you report, grade, and stage the entire case. And this is that critical divide. Is the cancer HPV-associated or HPV-independent? Because look at how different the paths are. If it's HPV-associated, you're using a totally separate staging system, you don't even need to provide a histologic grade, and something called extranodal extension, or ENE, isn't part of the end stage. But for HPV-independent tumors, it's the complete opposite. You must grade it, and ENE becomes a make-or-break factor for the end stage. Getting this distinction right is everything.
Okay, moving right along to Section 3, invasion and surgical margins. Now we're looking at how the tumor has been behaving in its immediate neighborhood. Is it playing nice, or is it invading the surrounding turf?
One of the first things to look for is perineural invasion, or PNI. That's just a fancy way of saying the cancer cells are wrapping themselves around a nerve. So why is this a big deal? Because it's a huge red flag for poor local control. And finding it is one of the main reasons the clinical team will decide to give a patient adjuvant therapy after their surgery.
Now, when it comes to margins, it's not just a simple positive or negative call. You need to be way more specific. You have to report the status. Is the tumor literally touching the ink? If not, what's the distance in millimeters to the closest spot? You also have to say which margin is the closest one. And for those HPV-independent tumors, you also need to report if you see any high-grade dysplasia at the edge.
Next up, Section 4. It's time to check out the regional lymph nodes. We've sized up the main tumor. Now we're going to follow the trail to see if it started to spread into the neck. And to do this right, you really have to know the geography of the neck. The lymph nodes are all organized into these very specific anatomic levels. It's so important that you identify which levels have cancer in them and report that clearly.
Now, within any of those positive lymph nodes, there's one feature you need to be on high alert for. It's called extranodal extension, or ENE. All this means is that the tumor has literally busted through the wall of the lymph node and is now growing out in the soft tissue of the neck.
So why do we care so much about ENE? Well, remember what we said earlier?
For those HPV-independent and hypopharyngeal cancers, finding ENE is a complete game changer. It tells you the disease is aggressive, it automatically kicks the PN category up a notch, and, just like PNI, it's one of the main drivers for the oncology team to recommend chemoradiation after surgery. This one microscopic finding has massive treatment implications.
And here we are, the grand finale. Section 5, synthesizing the PTNM stage. This is where we take all the clues we've gathered, tumor size, invasion, how many nodes are positive, ENE, and we put it all together to create the final picture.
But wait, before you start plugging everything in, there is one massive update in this protocol that you have to know. For nasopharynx cancers only, we are no longer using AJCC 8th edition. We've officially moved on to AJCC version 9. The other sites, the oropharynx and hypopharynx, are still on the 8th edition for now. This is a super important distinction to remember.
Think of this table as your ultimate cheat sheet for figuring out the PN category. For an HPV-associated oropharyngeal cancer, it's actually pretty simple. It's all based on the number of positive nodes. That's it. But for HPV-independent and hypopharyngeal tumors, it gets more complex. You need to factor in the size of the nodes, whether they're on one side or both, and of course, the presence of ENE. And then there's nasopharynx under the new AJCC 9 rules, which is different again, looking at laterality, size, if it extends below the cricoid, and even a concept of advanced ENE.
So when you boil it all down, what's the big takeaway? The synoptic report you're filling out isn't just a checklist. It is a precise, detailed map of your patient's disease. And every single detail you record, from the HPV status, to the distance to a margin in millimeters, to the presence of ENE, every one of them directly guides life-altering decisions about that patient's treatment. So the question you should always be asking yourself is this: how will the map I'm drawing right now guide this person's path forward?